exam room. I think that's not exactly.
Okay.
Yeah.
I want to leave it up to the pond.
Yeah.
So, fix up the audio.
It'll pick up the audio.
Okay. Blood pressure, feeling okay? Just a little bit on the lower side, but yeah. That's normal for you?
It's not, it hasn't been, but it is now.
Okay. And is that with the weight loss that you've had?
I don't know what it is.
Okay. Let me just grab my notes on you. Sorry, it's been a day. And so, you all are from Oakton? Or Oakland?
Uh-huh.
Okay.
Oaktown, according.
Yeah. And you live here?
Yeah, I live in Olympia.
Oh, okay. Great. So you're visiting? Do you have any other friends or family in the area?
Few.
Okay. Are you gonna stay here for Christmas?
No, we're just up for a couple of days for this consult.
Okay.
By the way, I've had Parkinson's about 20 years.
Yeah, I
So
see
that's
the
why
notes.
I'm not really speaking clearly, but if I
I
don't
can
speak
hear you.
clear enough,
Yeah,
you can ask me to speak more.
I will do so, but
Okay.
thank you for
Thanks.
letting me know. But yes, I did see in the notes that, yes, you have Parkinson's. And my understanding is that you don't quite drive, or
Well,
sometimes
some
drive.
days I'm much better. I'm actually
Yeah.
pretty normal.
Okay.
So I'll try that. Yeah.
Okay. Well, I'm gonna actually come over there, just so I can be a little closer to you. Let me put my cell phone in there. So I have my notes from the records that I received, and I always want to make sure if things are accurate. Okay, and I did get your list of questions, which I have here, which we'll go over. So my understanding, so just not other medical problems besides the cancer. It sounds like you had some cholesterol, maybe high cholesterol at one point.
I have seen that it's a little high. The
Oh.
doctors never seem too concerned about it.
Okay. It just says like you chart hyperlipidemia, and so I was like, oh, okay. I have down. I know you had some. It sounds like chronic back pain,
It's actually flamed.
flank pain.
Went on for a few months. Pretty severe.
I was reading some of the notes, and I know you had an injection at one point and it didn't work at all, and then you went to physical therapy. Did it work now?
They just basically said,
Yeah.
do what you're doing.
And then the MRI, there was like a little bit of a disc protrusion, but that's.
That's what clinically the Kaiser fixated on, was that it was a disc issue.
Okay.
I never felt like it was my back.
Okay. And so I guess reading through the notes, one of my questions was, well, is this related to the
That's my
cancer
question.
process, or is this not? It's not a classic presentation,
Right.
and this was which
It
link?
was right in here.
Okay, but I did see some pictures. They had put a little circle around, so it was over here.
Never radiated up or down my spine, no matter
Okay.
what positioning.
Yeah. And has that changed since your diagnosis?
That resolved before.
Okay.
Yeah, that resolved in about 2 months.
Okay. And so the last time you felt that discomfort was a bit of time ago. Okay. I'm happy that has resolved. That's not
Me
easy to
too.
deal with. That's reading the notes. It sounds like that was actually quite painful. I have down. You had a mammogram. It showed some calcifications. So they did a MRI or another
No, they
ultrasound.
did another mammogram.
Okay. And they said probably
Come back.
benign.
And they said come back in 6 months.
And I have down you've had your appendix removed, and that's the extent of your medical history. Besides what you're
Oh
going to talk
no, I
about.
had a fallopian cyst removed.
Okay. Benign.
Yes.
Okay. So you guys are in Oakland.
Yeah.
Okay. How long have you been there?
I've been there since '83.
Okay. And you were at Berkeley.
Pardon me?
You were at Berkeley,
As a student? No.
or as the director of was it public
Oh,
health?
I
nursing?
worked for the health department in Berkeley.
Oh, okay. Where did you do nursing school?
At Samuel Merritt in Oakland.
Okay. When did you retire?
5 years ago.
I have down from past notes that you enjoy hiking, bird watching, and theater. Is that true?
Mm-hmm.
Okay. Where do you do your bird watching?
In Oakland, in the Bay Area.
Yeah. Okay. What kind of theater?
Any theater,
I feel the same way. I'll see whatever.
except musicals.
I like musicals. So not musicals.
For the most part.
Let's see. I have down you are married.
Mm-hmm.
Okay. Mr. Hathaway there. You smoked for about like 12 years.
Yeah, it was like 17 to 30, 35.
Yeah.
Okay.
But-
So remote
Yeah.
and like 1 pack per day or less.
It would go from earlier it was a pack, it was probably a half a pack in the beginning.
Okay. I have down rare alcohol use.
Yeah.
Occasional marijuana. Is that edibles or is that
Now
smoking?
it is.
Okay. And how often?
I eat a gummy maybe once a week.
Okay. And is that for appetite?
I was hoping it was, but I don't seem to notice that it doesn't.
And let's see. I have down, you're also in the medical field.
I was a nurse practitioner.
Yeah. Are you retired?
Yeah.
Okay. Did you retire about 5 years ago too?
I retired about 7.
Okay.
Amazing.
Yeah. You're also doing the hiking and the bird
Yeah.
watching?
Mm-hmm.
Okay. And I have down your mom lives in Indiana. And just, there was some part that she did not know about your illness yet.
She does not.
She does not. Okay. How old is your mom?
She's 85.
Okay. And I have down that your father had stomach cancer in his late 60s?
I think so.
Okay. Is he passed away?
Mm-hmm.
When did he die?
Late 60s.
Is it of the stomach cancer?
Yeah, he had a stroke, and then I believe the death certificate was stomach cancer. I don't know if it was primary or not, but
Okay. Did he ever do chemotherapy?
no one did any cancer treatment.
And I have down your paternal grandmother had breast cancer.
Mm-hmm.
What age was she?
I don't know, maybe 60s.
And anyone else in the family with a cancer diagnosis?
Not that I know
Does anything run in the family? Anything else other than cancer?
of.
Well,
Diabetes on
diabetes.
my mother's side.
Okay. And then for meds, let's see. I have written down, let's see, it's morphine, not currently, okay. Was that during the radiation? You took the liquid morphine?
Yeah, it was to help me sleep, basically. It was
Okay.
painful at night.
And no longer needing it? Okay. And Zofran, how often have you needed the Zofran?
Well, I didn't take it very much at all, and then in the last week I started taking it, but then last night I realized I don't think it's nausea I'm feeling. I think it's like, because it's more up here.
Mm-hmm.
I don't know how to describe it, so I don't really think it's nausea, so I
Okay, okay. And then Ativan, you said maybe take like about twice per week.
yeah, if I want to make sure I get a good night's sleep.
Okay. Clearlax, constipation. Has that been an issue with the radiation? Or with, I guess, the morphine sulfate and the radiation?
Well, I think it's been from Zofran,
Okay.
and just not eating, I don't know.
Yeah, that could be. And then the THC gummies that we talked about. Okay. So Lisa, is it
Lee,
Lee?
L.I.
L.I. Okay. And then do you have any other physicians who are involved in your care this time?
Well, I have a general practitioner, but I'm not seeing her for anything.
Okay, so I'm just gonna, is it okay to send a note to Dr. Lee, or is that
Mhm.
important?
Yeah.
Okay.
I think you're talking.
Oh, it's not Lisa, it's Alice Lee, I'm sorry.
Alice
Yeah.
Lee. That's okay.
Even your primary should
From a
have
single
too,
one.
because she does
Yeah.
advocate for you once in a while.
And Oakland Kaiser.
Mhm.
Got it. Okay. And so, when was your dose of pembrolizumab?
Exactly a week ago.
So-
Last Wednesday.
Last
right?
Wednesday.
Yeah.
Okay. So like 12/18?
Today's
12.
12/18 today's today, sorry.
12/11.
I need calendar.
12/11.
12/11, got it. Okay, and then so the radiation, you completed that, was it on the 10th?
Yeah, the day before the.
And then you had 10 sessions. Okay. How'd that go?
It was fine. I was exhausted. I could swallow better.
Good. So it had the intended effect. What can you swallow? What kind of things can you swallow now?
I don't know. It's like a lot of things I haven't wanted to try, thinking I couldn't, and so now I'm starting to try them because I think I can. Sometimes they hurt going down. Sometimes the first bite is painful, and then after that I can eat it.
Mhm.
Sometimes it goes down fine, but when it hits my stomach, it hurts. So it's kind of all over the map.
Yeah. Is there, have you been able to swallow pills okay? And has it always been the case?
Like I can't drink big gulps of liquid to sip.
What about things like bread?
Bread has been problematic, but I haven't tried it for a while. I ate a croissant this morning.
That's
And I
fine.
dipped it in my coffee, and yeah, and it worked. It went down fine.
Okay, good.
But it kind of melts as you chew it.
And then what about things like, have you bigger, like pieces of meat?
I don't eat meat.
Okay.
I haven't done, like, I had a tiny bite of fish. It's more that it's not appealing to me than I can't eat it.
And have you been seen by nutrition while you have been through this process?
Mhm.
Okay, and what is their opinion about your caloric intake?
That it's crap.
Okay.
And I
And,
need to eat more protein, I need to eat more calories, I need to eat more often.
yeah. And then what about in terms of supplements? Have they been able to prescribe some supplements for you? Ensure things
Well,
about
they suggested Ensure, and I
Yeah.
just can't stomach it.
Sometimes people are like, no, it's the most disgusting stuff ever, but, yeah.
So, until I absolutely have to.
I guess how much do you eat per day? Has it ever been the case where they've talked about other feeding methods, feeding tube, for instance? Okay, so we're not there. They said,
They haven't said anything, I think there are days I'm lucky if I get 500 calories.
I don't have a good sense of how your weights.
Well, the
been.
weight was weird, so with the pain issue,
Uh-huh,
I didn't eat for 2 weeks at all,
okay.
just because I was,
The flank
yeah,
pain.
I was just crazed. And I didn't know what was going on, so I didn't want food in there.
Mm-hmm.
And then the next 2 weeks I'd eat, maybe a little bit of watermelon so I basically didn't eat for a month and lost 20 pounds. And then once I could eat again, I had been wanting to do intermittent fasting, so I decided to do it because since I'd already been not eating. So for the next month I did next 2 months I did intermittent fasting, but
Uh-huh.
right at the beginning of that, I started getting spasms in my esophagus, and so that made it difficult to eat many times. So I think that first 20 pounds was just kind of, I think, unrelated.
Yeah.
If the pain was unrelated to the cancer,
Yeah.
then that was unrelated. And then I was intentionally trying to lose more because I was like 197 pounds.
Okay.
And now it's just because of what I'm eating.
What do you think your weight loss has been over the past month? So for about 4 weeks.
Past 4 weeks, maybe 10.
So still actively losing weight.
Yeah, it's hard to say because my home scale is different than the scale at Kaiser.
Oh, yeah,
I don't know,
yeah.
it's different from yours. I was happy to see I was above 150.
Oh, yeah.
So if that's accurate, then I'm up a few pounds.
Yeah. Okay. I would be more than okay if you were up a few pounds. And I think with the radiation, hopefully eating a little bit more is just definitely going to work in your favor and make you feel better. So complications, so I'm hearing the radiation seems like it improved things a little bit, still has room to kind of improve a bit more. It sounds like fatigue was an issue, but otherwise tolerated okay? Okay, good. And Annie had the Pembro Fusion Go.
I didn't really notice anything.
Yeah, most people
The
don't.
fatigue didn't go away. I was kind of hoping I'd feel a little stronger, but that's kind of remained. But I'm not doing anything, so that would be related.
Yeah. With the so I guess the diagnosis. What do you understand about when they found that, when they went to do the EGD? My understanding is that you've been kind of having these symptoms for like a bit of time. What finally made you say I need something else? I need to get this taken care of. What finally made you say?
Oh, I
I
was
need
saying
this.
it way before that. It was
Okay.
just Kaiser was not doing it.
Okay.
They had me take, I had an original primary who put me on omeprazole.
I saw those notes for like 2 weeks, and that didn't do
Yeah,
anything.
it didn't
so
do
it was
anything,
like,
so we stopped.
Okay.
And then when I changed primaries, and then the spasming started, she put me back on, and she said, you may need to be on this for 2 months to see any results.
Yeah.
So I did almost 2 months. I ran out of medication, and I said, nothing's changing. I'm not taking this again.
Yeah.
This is not doing anything. And that's when she ordered barium salt.
yeah, and that didn't show anything.
And that's when they ordered the endoscopy.
Okay. And then I always go through the scans with the radiologists, just so, again, this is part of the,
Sure.
I always wanna make sure I have the full picture, and so I'm gonna be looking at the scans with the radiologist, so thank you very much for bringing those. From the reports that I have, it sounds like we know there's a known mass there that can be seen sort of thickening in the distal esophagus in the first portion of the stomach. And then it appears that there's lymph nodes that are quite suspicious. And looking, it sounds like it's not just regional lymph nodes, and it sounds like, at least from notes, that it might be more in the retroperitoneum area, but also there's been a question of peritoneal spread. And that's what I just wanna make sure with our radiologist, that we see. My understanding is that it's not elsewhere, is that correct?
I've never been told that it is,
Okay.
but I've not been extremely curious yet, so.
Okay, yeah. I'm just curious to say, I always like to make sure.
Yeah.
And per protocol, we always do request biopsy specimens, which we've not yet been able to get, but I would like to see at some point, or I'd like to have one of our pathologists look at, which we generally do for new patients in general. So I'm not gonna do anything special in your case. It's more of a, hey, I want our pathologist to look at it. What is your understanding about the pathology of what kind of esophageal cancer this
That
is?
was squamous.
Yeah, it was poorly differentiated carcinoma, but with a squamous differentiation, and so, I think we're kind of assuming this is squamous. It's in a little bit of an odd location for it to be squamous. However, there have been cases where you can still have sort of those cells in the distal esophagus and can present as you've presented. But I just want our pathologist to absolutely look. It would not change the management first line, second line, but it could inform other lines of therapy. And it would be important if there's a hint of it being an adenocarcinoma instead of squamous, that can open the doors to more clinical trials. So it's more about, I just want to make sure that, let's just make sure we agree that it's squamous. With this, let's see, your doctor did get tumor markers, the CA19-9 and the CEA, and those are normal, which we do expect with a squamous. And so that's also pointing towards, I think that's definitely what this is. And we'll talk about why that's important.
Can you say what those are again? I'm sorry, I'm trying
Oh,
to take
yes.
notes, so I just wanted to.
CA 19-9
19-9,
and a CEA.
okay.
And those with adenocarcinoma, those can be elevated, not necessarily, but can be.
Mhm.
But for squamous, generally, we're like, that's not going to be the case.
Okay,
And then your doctor also tested for PDL1 or CPS, which is why we put you on Pembro. And did she also tested for, let's see, were there any other
She did test for another one.
mismatch repair? Yes, mismatch
She
repair has
did
been
do
completed and it
mismatch
is
repair.
mismatch repair proficient. Got it. And then she also tested for HER2. And I know, I like her note saying it's probably squamous, but I think it was, you always just wanna make sure, especially with this. We're not sure, but we're pretty sure it's squamous, that was negative, as expected. It wouldn't have changed prognosis, but it does change some of the therapies that you can give. That's why we test for it. Let's see. So, do you have they place a port already?
Mhm.
Okay. And yeah, had the radiation and then the pembrolizumab. And what was the discussion about, like, the chemotherapy, the possible chemos or the possible treatment options? Tell me what you guys have talked
I
about.
don't remember there being much detail at all. It was basically that the Keytruda would be as effective, if not more effective than the chemo if I responded to it. And that chemo would be an option, but we didn't talk specifics. Do you remember anything?
No, I
about
think that's
that?
pretty close to it, yeah.
Yeah, it's, you know, we definitely would advocate for chemo in the first line if we kind of thought that somebody had some disease bulk that we really wanted to get down. There is some suggestion that, yes, Pembro would work, especially because of your CPS score. It's a little non-standard to use it first line, but I think, you know, it still could be, I think it still could be of use. And
What could be of use?
the
Chemo?
pembrolizumab. Yeah, so I don't think it's wrong to do that. And, you know, my hope is that, yes, that your CPS marker does portend a really good response, hopefully. You're looking a little bit tired, and I'm kind of thinking, well, I know you're traveling and you're away from home. We don't expect, it takes a little time for immunotherapy to exert its effect. And so that's why if you need a little bit more of a rapid, if you're trying to get a little bit more of a rapid turnaround, that's when I think chemotherapy would be most of use. Especially if there's a mass that you're trying to kind of decrease. But I can see her thinking that, you know, we're gonna do radiation to try to debulk, and then in the sense of no other very bulky disease or symptomatic disease, that you had this kind of time to try to see how things work. And so, you know, I do see the rationale. With squamous, it's generally, it's generally more used in the second line. And if for adenocarcinoma, it's generally for third line, but there is a trend to using it earlier, even earlier. And so it's not standard, but I still think it's reasonable.
Is there, I'm sorry, is it okay if I ask?
Yeah, right.
Is it, two different questions, I guess,
Yeah.
related.
Yeah.
One is, can you use them together? In other words, can you do chemo and
That is
Pembro?
in trial, so that one of the trial that looked to see, you know, can pembrolizumab be used earlier, they compared it to chemo and also to Pembro plus chemo.
plus chemo?
And it's not, the data's not there yet to really start using immunotherapy
Mhm.
plus traditional chemotherapy, at least, you know, Pembro plus FOLFOX.
Right.
But I think at some point we'll probably be moving that way, but not approved.
But not approved.
No, and definitely, every time you add more agents, you get more side effects.
Yeah.
And so you're kind of like, well, you just have radiation, and so that would be something we would definitely need more data on before ever, yeah. Even if it was approved before entertaining that idea, but no.
So the second half of the question is then, so she's had one dose of
Yes.
of Pembro.
Yes.
If they decided they wanted to do chemo, is there any reason why she couldn't stop the Pembro and start chemo, or how does does that need to progress in a certain way?
Yeah. So with any line of therapy, once you start on it, we don't waste it. Meaning, you started on this route, let's continue on it. And that is because, well, that impacts clinical trials later on down the road. So say you get mileage out of pembrolizumab, and say you get disease shrinkage and you have a great effect, and at some point you need to change therapies, there might be a wonderful trial saying only after one therapy, progression on one therapy, can you go on here. If you've gone from chemotherapy, even if it's just one dose of each, you've had 2 lines of therapy. And then it makes it tricky to see what side effects from one versus the other. But then also it makes going back using immunotherapy again a little bit tricky because your body's already seen it. We don't know if there's going to be some kind of we've already seen this medication, we're not going to respond so well right now. So we don't waste lines of therapy. It's more of with pembrolizumab, or with any regimen, we would recommend that somebody be on it until there's evidence that it's no longer controlling the disease, or there is a side effect that you find completely intolerable, and that despite optimal management, it's still intolerable. So we would say continue on unless either of those 2 scenarios happen.
And aside from how she's feeling, how do we know whether there's been control?
So that one is going to be based on, well, number one, again, as you said, how she's feeling. A lot of times with esophageal gastric cancers, people over time feel a little bit better on treatment if it's working. And I know you were feeling better with chemotherapy. It's a little bit of an odd kind of an idea, but people do feel better.
Yeah.
But also it'll be, if there is a tumor marker to follow, that's an early indication. There's not in your case, but what it's going to be is looking at the scans. And so looking to see what these lymph nodes are doing. You can get not much of a sense about what this primary tumor is. It's difficult to measure an esophageal mass just because it's something in a tube. You don't get the best measurement, but you get some idea on scans. And so it would be a CAT scan of the chest, abdomen, and pelvis.
Okay.
And that would be, immunotherapy takes a little bit of time to work, and sometimes you can have something called pseudoprogression where it looks like something is getting bigger, but it's not really. And so if you look too soon when you've started immunotherapy, it could give you the wrong impression that, oh goodness, things are growing, when in reality it's more of that's an immune effect, it's okay. So generally we don't check. 8 weeks would be a bit too early. It would be probably about
So it'd be after like 3 treatments.
probably around like 4 treatments. Yeah.
So that's talking about the main tumor, but what about mets?
Yeah, and so the metastatic disease, it sounds like there's some lymph nodes that were concerning. And that's what I think is going to be more measurable on a scan. And so you can measure those lymph nodes pretty well. And then so you can tell from scan to scan, how have they changed? Have they increased in size? Have they decreased in size? Lymph nodes can be increased because of infection, but if it's cancer and you see lymph nodes growing, that's from the cancer. And if you see a lot of lymph nodes decreasing and you've given them treatment, then you think, well, okay, yes, that is probably most likely the treatment working rather than an infection resolving. Because we have a baseline scan, and that will be allow the radiologist to compare to see how have things changed with treatment. And so it'll be based on how you feel, but also what does it look like on the scans. Let's see. What other questions about, I guess, how things have happened initially and the workup, and then also the treatment that we're on right now? What other questions do we have?
Well, I think on the workup, I guess,
Uh-huh.
initial, I think when you do get a chance to take a look at the CTs that were done initially, just to
Yeah.
see what, because,
Yeah.
I mean, I'm not sure whether you can grow back your appendix, I'm sorry.
Yeah.
Because this initial CT says she's got an appendix.
Oh,
there.
whereas we said you had your appendix removed.
Right,
Okay.
so,
Okay, yeah, well, I'll look at that with the radiologist. Generally, a lot of times when radiologists are sort of reading a scan, they'll
Yeah.
kind of just be like clicking
right,
boxes.
that's what I was thinking,
But we'll double check.
yeah.
And there's these report of these kind of, the thing that lines the abdomen, kind of a peritoneal
Mhm.
spread. I'm sorry, you're in medicine, sorry.
Human,
Peritoneal carcinomatosis. There's some
Okay.
little omental nodules, and
I'm in medical, but I never did any
Ah,
oncology, so
okay.
please.
okay. So the omentum,
Yeah.
or the peritoneum covering the abdominal cavity,
Okay.
that's a place where there can be metastatic disease, and sometimes it's difficult to see on imaging. Although when it can be picked up, it's often more of a, oh, we have seen that. There was a suggestion of omental nodules on the scan, and so that
Scan.
let's see, the CAT scan from November 8th. Poorly defined infiltrative nodularity.
The PET scan too.
Yeah, and in the PET scan, something has to be really, they said small ones. They were not as bright as the mass that we know about, and then so the lymph nodes somewhat bright, but if it's that small, a lot of times you're not going to be able to see it that well. However, it was a little bit bright to suggest that yes, that is metastasis. Before I go on to these questions, I want to see what other questions you have, or if we could start with these questions, and you'll think of things then.
Mm-hmm.
Yeah. Okay. Okay. So, are these your questions or his questions
They're
or both?
everybody.
They're everybody's questions. Okay, great. And if you
Tom
guys,
actually has done a lot of research on this in the past.
okay, great.
So,
And so, if you have any, if something requires more explanation, if you think of something else, just please let me know. But in the meantime, let's just go through them. Okay. So testing. Is there any more testing that can and should be done that would help the decision making? And so short answer is no. The ones that you generally get are the PD-L1 or the CPS. Sometimes you get the HER2, and then this mismatch repair, which you are mismatch repair proficient.
And that means that that's a good thing or not such a good thing? I can't
It's-
figure out what the word proficient
I mean,
means in this term.
It just means that, if it is mismatch repair deficient, that can
Okay.
be a marker that maybe you have this thing called Lynch syndrome, but it also could portend immunotherapy might be helpful in this case. Well, you have a CPS that is 15, so we know from that immunotherapy we think will be beneficial in your case. So either way, those tests, it's a immunotherapy, yes. Well, we already know from this other test that immunotherapy might be good. So
Okay.
there is next generation sequencing, and that's where they look for a large panel of mutations.
I was just reading about that this morning.
Yeah, most of the time, especially with something like a squamous cell of the esophagus,
Mm-hmm.
a lot of the time we don't get anything actionable, meaning we can know what mutations a tumor has, not ones that you were born with, but mutations that your tumor developed over time. And unfortunately, a lot of times we look at that and say, oh, there's nothing, we have no drugs to target that specific mutation. Sometimes we get lucky and we find something that is completely unexpected, and such as something called an NTRK mutation. Well, we got something it's a clinical trial and it's very experimental, but we got something that targets NTRK. So in the event, it would be very rare that would happen in general. That is something to think about. It's sometimes insurance covers it, sometimes they don't.
The testing.
Yeah, and I know Kaiser. I don't know their, I don't know their policy on it. Generally, it doesn't really come up with anything new. You know, it would be rare, but still, it might be worth it. And if that's something you would want to consider.
Is it something that would be done now, or something that would be done once you understood whether or not the Pembro was working?
Well, so it takes about 2 to 3 weeks for the information to get back. And so I do think that the next treatment should be FOLFOX, should be chemotherapy, if that's within your goals of care. But, and I don't think that you would want to go on to something experimental until you have been exposed to chemotherapy. So it would be more of a, no, it takes a little time to come back, but there's no right time to get it. There's not, in my mind, I don't think there's a rush right now, but it's better to sometimes have that time before you really need those results.
So are you, I don't know, suggesting is the right word, but
I'm recommending considering it.
chemo? That's my
Oh.
question.
No, the next gen sequencing. So the chemotherapy.
But it sounds like all roads lead to chemo.
Well, so once the disease progresses on immunotherapy, and we hope that you get a good amount of time on this, there's really, the only other options are chemotherapy. And chemotherapy can work. And the FOLFOX medication can be decently tolerated. In any treatment that you get, it is very much, you do need to think about quality of life. And I know that reading from the notes that's been something that's been important to you. I do think, and again, people can feel better if they have a therapy that is working. And so I've had people, again, feel much better on chemo. And so I think at least considering it for second line, I think would be good. But you can say, you know what, no, I absolutely don't want to go down that route. And that's perfectly acceptable. But next, if next line therapy, if you decide, yep, I want to try something after this, and if you're strong enough to do so, the only other option is chemotherapy. Okay. I would say that it might be worth a try. It can be stopped at any time. You've not committed yourself to anything. But I think that'd be worth it. So right now, you don't look like you're feeling all that great, and this has been months of symptoms and just not feeling good in general. Okay. And I think even if it's chemo, if it makes you feel better, then that's worth it. It's all about quality of life. All right, now with the pembrolizumab, generally, yes, it's better tolerated than chemo. It can still have some side effects, but still, it's worth giving it a shot. What are there questions about? Because I know down here we kind of have, you asked a little bit more about like other therapies, and so we will get to that. But the next one after pembrolizumab, I think, should be FOLFOX. Should surgery be considered? Short answer is no. When the cancer has gone outside of the esophagus or the stomach, in general, the thought is if you can't get all of the disease, then you shouldn't try to get any of it, because it is a very, very big operation, and it delays your time, the time that you can get systemic therapy. And so, generally, no, it is not done. I have seen things where if there was one tiny lesion in the liver and an esophageal mass in a young 30-something-year-old, people have been more aggressive, and that person did ultimately go to surgery, but that would be, there was no lymph node involvement, there was no mental involvement. And that was something that was non-standard, and it recurred. There look to be numerous potential chemo regimens available. What combinations are available, and what are available in clinical trials? There are a couple of sort of, we call them our gold standards, ones that we know work the best. And the one that we know works the best, and the one that why we reach for it pretty right off the bat, is this FOLFOX. This is the 2 drugs. Okay. That one is based on clinical trials, the one that we know has the best track record, is the best sort of tolerated at least, and we think has the best likelihood of disease control, which is what we're after.
Mm-hmm.
Okay. And so that is, it's not a new regimen, but there has not been anything that we have that has gone above and beyond, with the exception of now that one study showing that maybe pembro might be a little bit better. It's still early data, but that's kind of eventually what we look at and what I think the field might be going towards. But right now we do FOLFOX.
So chemo, what I understand of chemo is that it would, from other, generally probably 2 experiences with this from other friends, is that chemo has really decreased everything to the point where they lived another couple of years, and then they needed it again. I mean, this was for a different type of cancer. They needed it again, and did it okay for another couple of years, and then they weren't able to take it anymore because it was causing too much of a reaction, and then she died.
Okay.
But is there anything that we're looking at? I mean, are we just looking at palliative on this?
Yeah.
To decrease pain, it's not to, because this is going to just keep on. So we're not going to be looking at periods of tremendous amounts of relief.
What I'm hoping for, and when I've seen the kind of, for best case scenarios, when we kind of look at something like this, I'm hoping for symptom relief. I'm hoping for the pain with swallowing, the ease of swallowing. I'm looking for the pain to decrease. I'm looking for the ease of swallowing to get better. I'm also looking for energy to increase. And I'm looking for, I would want the other sites of disease to not get bigger and to not have new sites of disease. If things shrink and that's what we want, it's great. And if things get a little more controlled, energy can improve. But it will not go away.
Mm-hmm.
There are times when we can, there are not going, in this type of cancer, there's not times where you can be off of therapy for a long time.
Mm-hmm.
You can by choice.
Mm-hmm.
But if something is working, and if the patient's tolerating it well, we would continue until either something about their blood work or how they looked made us stop, or if the cancer was growing. This one, cancers of the esophagus and the stomach, they're tough ones. And we don't have years. There are other lines of therapy after the one that we talked about, that FOLFOX. Each time you go to at least with a chemo regimen, each time you go to a different chemo regimen, we think that you get less bang for your buck. And that things, and some of it is the patient's a little bit more tired. Their bodies, things accumulate, and also the disease develops mechanisms of resistance, which is unfortunate.
Okay. Gotcha.
Have you talked about numbers yet? Okay, is that something you want to talk about?
Sure.
Generally, nobody's average. Okay. Life expectancy for this, we think about around 11 months, 12 months. If somebody has a wonderful response on immunotherapy, we know that that can be a very durable response. It can last for a long time. I have seen other people who, despite what they're on, with each next scan, the disease does not respond. And so they're not looking at 11 months, they're looking at less than that. It's a spectrum, but that would be more the average. And some of the questions about, well, what are the other chemotherapies that you can use? So we go for FOLFOX, and then we know that the next one, and this is something that is done, is in basically guidelines. Well, kind of more or less guidelines. At that point, when you're talking about second, third line therapy, you can kind of see what you think the patient's up for. Then you're looking at things like paclitaxel, docetaxel, and irinotecan. Those can be a little bit more difficult to tolerate. Those start to be associated with a little bit more hair loss. FOLFOX does not have hair loss, but they have their own set of symptoms. And again, when you get to second or third line therapy, sometimes again you don't get as much mileage out of each regimen. One of your questions sort of ties into that, the ramucirumab, and for a lot of the cancers of the gastroesophageal junction and gastric cancers, our gold standard second line therapy, so we have the most data, is this thing called paclitaxel and ramucirumab. That has though only been tested or used in adenocarcinoma, which is a squamous. We don't have good data to suggest that adding the ramucirumab would work. And then you always have to think, well, if I don't know if I really have no clue if it's going to work, but I'm pretty sure that at some point, yes, it has side effects, then you kind of have to think, is it worth it? In the lung cancer world, you also have this, some of them are adenocarcinomas, and some of them are squamous. And there's this one relative of ramucirumab, it targets VEGF, Avastin. You can use in adeno, but you can't use in squamous because there's an increased risk of bleeding. But then ramucirumab has also been used in lung cancer, and you can use it in squamous or adeno. And so I'm saying it just has not been studied in squamous cell carcinoma of the esophagus or of the gastroesophageal junction. If it was adenocarcinoma, I'd say, yeah, probably want to use that. I would say I have no good data to support that use. And so I think it's more of a conversation, and it's more of a seeing what Dr. Lee, well, will insurance cover it? Was Dr. Lee okay with it? How do you look at that point? So I would say the ramucirumab right now, I would not. That's not next line therapy, and so have that discussion a little bit more later on. There might be data to support its use, but there might not be. The short course radiation, that should not affect future treatments. That should not affect trial participation. That is something most trials write in if you needed palliative radiation for comfort, for symptoms, to start swallowing again, that is most likely not an exclusion criteria. Clinical trials are a bit strict, and they have very specific requirements. And so if it was a trial on radiation to the tumor, well, no, they're not going to re-irradiate you, so you would not be eligible for that. But if there was a trial for chemotherapy or systemic therapy, that would not disqualify you. Clinical trials, though, for gastric and esophageal in general, they're hard to come by. This is, when you look at the numbers of patients with, say, colorectal cancer versus esophageal gastric, colorectal cancer much worse than esophageal gastric. And trials tend to be a little bit more on the scarce side, unfortunately. In addition, the adenocarcinoma versus the squamous, that's also an important distinction. We don't have any trials at this point for, well, we only have a couple of gastroesophageal cancers. And even if you were adenocarcinoma, that you would not be eligible for anyway. But we don't have anything specific that says squamous. There's our phase 1 group, which sometimes can have, which is a little bit more experimental. They don't have anything currently. But they are the ones who, if you have a tumor with this specific mutation, all comers, whatever tumor you got, you can go and get that treatment. But I think clinical trial participation, while in general I do encourage it, you have to make sure that it has to make sense for you, and you have to make sure that it's something that still allows you to have good quality of life. If you do go on trial, you have to get all your blood work, all your scans, and all your visits at the place where you're having your trial. And so it would be just more of a, if you're ever looking in the future, clinicaltrials.gov is an awesome website, but it's also seeing, where would I mind spending some time? And if that's a, hey, I got a friend in Olympia, or I got a friend up in Seattle, and then it would be like, okay, reach out to us again and say, what have you got now? Or if you got friends in Texas, you're in Houston, you're like, oh, I want to go to MD Anderson. That's okay too. You can get a good idea more or less of what clinical trials are offered based on clinicaltrials.gov. Sometimes it's not as updated. For instance, there's this one trial that I've put patients on where it says we're recruiting. It's like, no, all of our spots are now gone. That's for our colon cancer study. But if that is something that you would want to pursue maybe later lines, I think that would be a thing to look at. But also reaching into Stanford, other UCSF, other places in the Bay Area. You've got a lot of good institutions there. Kaiser, they sometimes, like, at least in the Seattle area, they've been a little bit, they have the reputation of being a little stingy in terms of approving clinical trials, but I've got a couple of Kaiser patients who I have on trial, so it can be done. If there is a trial that is attractive and that you qualify for, and if you want to do, again, I think you can. But it's more of it matters. I would not stop something that's working for you to go on a trial. And I think the time to look for something is when you need to change therapy. Clinical trials, they open, they close, and so what's available now is not what's going to be available when you need extra treatment, when you need to change treatment. So that would be the time to consider, standard treatment? Well, and when I say standard, I mean, we think it works pretty darn good, versus, hey, what else is out there? Is radiation something to be considered again in the future? Not to the tumor, not to the esophagus. If there was a spot, I've had some people who say have like a painful spot in their rib, and doing a little bit of radiation to that much improves their pain level. If there was something where we thought doing radiation would make you feel better, yes, you could entertain radiation. But this tissue, from looking at the dose and I'm like, that's had enough. You can't do more radiation to it. Are there any tumor infiltrating lymphocyte type vaccines being developed or available in trial for this type of cancer? No, unfortunately, no.
Mhm.
That is something that is very in its infancy.
That's my question.
Yeah,
So, sorry.
it's okay. No, it's all good. It's in its infancy.
I have a son
It's-
with stage 4 melanoma who's in remission. He's doing great.
Oh
but
yes, yes,
TILs
that is.
are definitely a thing for
Oh yes.
for him as a possibility if he needs
Yes.
in the future. So
For
I
melanoma
just had to ask.
And for those, that is something that, yeah.
So,
Um,
okay.
And, you know, a lot of times in the gastro and the GI cancer world, immunotherapy, it's nice when we can use it. You know, now we have esophageal-gastric, but we can't use it for colorectal, it just doesn't work. We use it a little bit for liver, but most of the time it doesn't work, but it's melanoma, it's really, it's been a game changer for melanoma, and, yeah. Chemo radiation treatment. No, did they talk about adding the chemo with the radiation in the past? Okay, okay. Sometimes they do it to kind of make the radiation work a little bit better. And, you know, they might have said, well, no, we can just do it okay with just the radiation that you had. And so I don't have any of the radiation documents, but chemoradiation, a lot of times you would combine those two. But sometimes if the patient can't swallow well, then you would say, I can't do the chemo pill. It's a chemo pill plus radiation. Let's see, what kind of monitoring for success and how often should it be done? And that was the CAT scans.
Yeah.
Right.
And I think after about 4 cycles, to just let it give that time to work would be probably the best. Again, you don't want to look too early because the
Mhm.
risk of pseudoprogression, and you might think that the treatment's not working, whereas maybe it really is. And what would you choose if this were you or a family member? That's difficult. I think, you know, if we didn't need a really fast turnaround and if we didn't have bulky disease, I would say it would be reasonable to try the pembrolizumab as you are. I would say you would probably want to try the pembro. But I think, you know, seeing the things that I've seen from these patients, I do think though that chemotherapy can be very helpful too. And we hope that the immunotherapy works well for you. And when it works, it can really work. It's a little bit frustrating in that we can't predict. We have no way to predict how, you know, is it going to work? Why does it work in this person and not this other person? So we have no way to say you're going to be one of those good responders, or no, we have evidence you're not going to be one of the good responders. We don't know.